Welcome back, everyone. My name is Bethany Hamilton, Director of the National Center for Medical Legal Partnership. You're joining us today on Zoom meeting, so just take a moment to make sure you hit the mute button on your microphone. The reason we're joining on Zoom meetings rather than webinar is because we want to ensure that today's final session, a town hall, is really treated as an open forum so that we can have a conversation rather than do this as more lecture or didactic presentation. So welcome to the final session of our Health Center MLP Planning, Implementation, and Practice webinar series. This final session is called the MLP Town Hall. Every summer, NCMLP hosts a town hall, and we're using this webinar series to host an interactive open forum on MLP planning, implementation, and practice. Today is June 27th, times 1 p.m. Eastern time. Let's go to the next slide. Just want to make sure that we continue to acknowledge and thank HRSA, the Health Resources and Services Administration, for funding our training and technical assistance work that helps health centers and other primary care, as well as hospital systems, really leverage, those MLP strategies to better address the needs of the patient populations they serve. The contents that we shared on this entire webinar series, as well as our resources that were funded by HRSA, don't necessarily represent the views of the agency or an endorsement by them. So I just want to note that this is HRSA funded, but not necessarily endorsed or representative of their views. All right, so housekeeping. Let's go to the next slide. Make sure. All right, thank you. And apologies in advance because several of us around the country are experiencing some Wi-Fi or IT issues, so just bear with us. Send us a chat if you need any technical assistance, or if for some reason our audio or video or the slide doesn't show up. So you are joining on Zoom meetings today. Please take a moment to just hit mute. There should be a raise hand feature, but also we're trying to host a conversation. So just ping us using the chat if you'd like to raise your hand to engage, and you may see that icon sprinkled in, but you'll also hear me throughout today's discussion encourage you to participate. So speaking of participation, let's launch the very first poll and see who was able to join us today. Reha, if you go to the next slide and help launch the poll, thank you. So folks will see on the screen a slight variation from what we've been asking thus far through this webinar series. For today's town hall icebreaker, we just want to know, what service sector do you represent? Are you from healthcare, legal services, or an other category? And there's some examples built in there. And then finally, as is the norm, tell us, does your organization have a medical legal partnership? We know we have a pretty small group today, so we'll wait for just a couple more people to respond. Let us know if you're from healthcare or legal or other, and do you have a medical legal partnership? All right, let's close the poll. Good, we have a pretty good mix today. As folks can see the results on the screen, you can see that about half of you are from healthcare, the other half from legal services, and then we have folks in the other category. If you are in the other category, let us know where you're from using the chat. And we are almost split in terms of those who do and don't have a medical legal partnership. So welcome back, everyone, for the final session, which is an open conversation about medical legal partnership practice through implementation. Planning, practice, and implementation. Let's close the poll and move to the next slide. All right, so just to recap, as if you're not new to this series, this should look pretty familiar. This is where we've been, and we have another slide just really showing a roadmap of all of the different topics that we've addressed. But we've been using the Health Center MLP toolkit and partnering with Texas A&M University Institute for Healthcare Access, as well as Professor Jay Siklik from UConn, to really help everyone walk through that toolkit to better understand, first of all, the core components of medical legal partnerships, how to then identify and engage legal partners, how to use MLP to drive change or address emerging issues, how to change some of those practices to engage in better practices related to developing workflows for screening, referral, information sharing, and integration of legal services in your MLPs, And then really, how do you implement legal needs screening practices to better understand the social determinants of health? Let's go to the next slide. This is the roadmap displaying how we've addressed several of the topics and how they correspond to the topics in the toolkit. And Reha on our team has also, and when you receive the slide deck, she conveniently linked each of the slides and recordings related there too. So you can see that we helped folks first lay a strong foundation, starting with addressing what SUH problems an MLP may want to address, all the way through to looking at sustainability in terms of messaging. So how do you really ditch that elevator pitch to create more effective messaging for your different MLP audiences? And then we went into implementing workflows by talking a little bit more about trainings to strengthen the MLP workforce. So we wanted to think about that a little bit more broadly in terms of using your MLP to work for you. And then finally, you can see that more recently, this is where we brought in the Philadelphia legal assistance team to talk about how they're moving OUD and SUD care upstream through their medical legal partnership. All right, let's go to the next slide. And as folks can see in the chat, that Reha has shared a direct link to our PIP webinar series, where you can find all of those slides and recordings. I want to acknowledge and sincerely thank Keegan Warren, the Executive Director of the Institute for Healthcare Access at Texas A&M University, and Professor Jay Siklik, adjunct professor of law at UConn. He's also the former MLP Director of a Connecticut. Sorry, Jay, I put you in Canada just now, of a Connecticut pediatric MLP. We are joined by Jay today, Keegan Warren, and then we also have one of our guest speakers from one of the sessions joining us. From the Georgia Legal Services Program. We actually may have a couple of the individuals who presented with us on today's town hall event. And so we'll call them out in just a moment. Reha, let's go ahead to the next slide so I can identify and thank all of those guest speakers who joined us. So folks can see that these are some of the guest speakers that we invited to help us better tell this story of MLP planning, implementation, and practice. You can see Ira Foster from Georgia Legal Services Program, Rachel Henderson, who's actually online with us, Tara McIntosh, Malik Hines, who are also part of the Georgia Legal Services Program MLPs. We were joined by Kate Marple, who helped us think about how to craft an effective messaging as well as training events. Margaret Robinson, James Tidrington, and Aaron Davison, who talked about the Philadelphia Legal Assistance Program and its ROI and evaluation, and Emily Foote and Julie Branfield from New York City Health and Hospitals and NILAG, respectively, who helped us understand information sharing and what they did to really leverage the EHR and the legal teams being in there to advance their medical legal partnership practices. So just wanted to once again display our panel of subject matter experts, some of whom are joining us on today's town hall event, and really thank them for helping us craft effective training resources for everyone going forward. Let's go to the next slide. All right, so here are our learning objectives. Really, these are conversation objectives. So for today's event, as you signed up, we want to have everyone really present some ideas. They're ideas that, and we'll facilitate some of this, that we hope others on today's session will then provide some constructive feedback about as MLP peers. Then we'll launch into a conversation about strategies that really help to enhance the integration of legal services into healthcare settings. I want to encourage everyone to, talk about what is really challenging us as a field in terms of moving forward with legal services integration into healthcare. And then we'll end with a discussion about tools or methodologies and real world applications of MLP that help to address health equity and outcomes. Let's kick off the conversation in that first area about presenting MLP ideas with a poll. So I'd like to ask everyone, just warming people up for the conversation here, of the options below, using the poll. If you have any trouble with the poll, use the chat. Please select your top 3 priorities for MLP practice or innovation initiatives over the next year. Just select your top 3. The first option is new partners. by type or volume. Perhaps you want to reach more or new patient populations or clients. Maybe you are interested in really addressing different problems or needs, or more problems or needs of the people that you serve. Maybe you're looking at implementation improvements. Perhaps you're trying to better understand or collect data or demonstrate outcomes of your MLP. And then we know a lot of folks are in the category of wanting to work on funding strategies. And so it could be more funding, sustainable funding types, or diverse funding, but broadly speaking, funding categories or funding strategies, excuse me. All right, give folks a couple of seconds more to select their top 3 priorities to work on for MLP practice or innovation over the next year. All right, great. Let's close out the poll. Great, let's show the results. So we can definitely see, based on the results on the screen, that most of you have ranked almost an equal part implementation improvements as well as outcomes at the top of your priority list. It's really quite even, 8 and 8. And then several of you have indicated that funding strategies are towards the top of your list in terms of priorities. Interestingly, finding new partners by type or volume is next in the list. And then patients or clients served or problems or needs addressed comes in last, but it is certainly a priority for several of you who have joined us today. Let's go to the next slide and really open up for a discussion. So at this point, what I want to do is ask volunteers in the audience to really talk amongst us, this group as peers, so that we can find out a little bit more about what you all are actually working on in terms of medical legal partnership practice and innovation. We would encourage you to, keep what you share pretty concise, excuse me, but maybe share some of what you're working on in terms of problems that are addressed or solutions that you're proposing. Let us know what you have in terms of implementation steps or expected outcomes. Feel free to highlight any challenges that you might be facing or how they were overcome. So I'd like to turn things over. This is a town hall where we all speak to each other, and ask if we have any initial volunteers who really are hoping to hear also from their colleagues on the line today about innovative ideas or practices related to MLP. And then in reaction to what is shared, we'd love to hear from a peer about how someone can refine or enhance that idea that they've shared. Who wants to kick us off? Awesome. Hi, Margaret. Go ahead and unmute.
Hi, I'm not technically an MLP peer, but probably a few you know. Well, I'm really all about the advocacy for social work inclusion. It seems like a lot of research I've done into MLPs doing great work. However, there are patients falling in between the cracks. And actually, I do have a question. It might not be here where it's addressed, but I wonder about the research about patient referral failures. I mean, there is a little bit out there, and one missing piece is, not having a more structured social work inclusion, because that can cover a lot of the issues that end up being issues with a patient referral failure. So anyway, that's what I'm working on, is how to more formally and in a structured way, adding social work, bringing them to the table with doctors and lawyers as well in an MLP setting.
Mm-hmm. I know we have Jay and Keegan on, so I don't know if they want to respond to that first. Jay and Keegan, do you want to take a stab at that first, or allow? I'm keeping an eye on our audience as well to see if they want to chime in. Thanks, Margaret. Appreciate you posing that question.
I will jump in, and I will just start by saying that my experience on the ground and as a researcher is that social work is critical to medical legal partnership. I think that it is really important not to over-index on the term medical legal partnership. I think if I may, you assume that lawyers and doctors have really big egos, and that's kind of what we're playing to a little bit in that terminology. I think that you're right, that it would be that there's opportunity to be robust about how we're measuring the impact of social workers in the address of health harming legal needs, because it's a continuity, right? Social workers, there's a reason social workers also work often in legal aid offices. There is such a continuity, such a continuation from license to license. I think there are other opportunities as well. So in Texas, for instance, continuing legal education counts as CEUs for social workers, right? And I think it's because the idea is that we want to train together, because we want to work together. I have some other ideas, but they're a little more nascent, so I won't share them right now. But I really just want to lift up what you were saying, and also let you know that although we haven't had the chance to really interact, if you get any random students from Texas, it's because I told them that you were the one they should talk to about about behavioral health and MLP.
Yeah, if I may, I don't have a lot more to add than what Keegan just put forward, but I have two, I guess I have two thoughts, Margaret, and everyone else, is that, again, you know, what's passed as prologue, if knowing the way that MLPs organically grow from the inception point up to the time when things start, you know, producing data, seeing clients, dealing with specific health harming needs, looking at inequities, whatever the focus is, the absence of social work presence is almost a death knell to the medical legal partnership. And I've seen it both ways, from the inception was in from the first day, because I think there's sometimes a misconception from the social work side that this is a new endeavor that's coming in to occupy turf that's already existing in the social work world. And then that creates I think an animosity that is, it's almost, you almost can't overcome that, right? So I think that in order to effectively get a program off the ground, the first meetings, the inception, the formulation of the, you know, what are the goals, what are the objectives, what are the metrics, having individuals on the social work side as kind of like, if you look at it, a three-legged stool instead of the medical legal, but a medical legal social work partnership enables and enhances the opportunity, because every social worker I worked with who immediately understood the value and presence of an MLP created a better MLP for their participation and partnership in that. And so, you know, so what's past is prologue, working on a new project as I speak. I'm extremely aware and understanding that this has to be a kind of symbiosis between the social work contingent and all the folks who are starting to work on the clinician, the medical clinician, and the legal side. That by honest, open conversations, and also utilizing the opportunity to already had experience to lend that particular value into the new incarnation. I don't know if I'm making sense, but I think I've seen it both ways, and I've seen the absence of social work actually create a barrier and impediment to a successful implementation. And I think, you know, individuals who understand the value of the partnership know that it can be greater. It's more than the sum of its parts with that social work part included. So as I'm kind of working, as we're talking, creating a new project, that is essential because there has to be that, there has to be that productivity of cooperation and collaboration, because there's so many unmet needs that span far beyond just the legal or the health harming legal. It's also the, kind of standard of living and the hierarchy of needs, if you will, that are often so unmet. So yeah, I mean, I think your point is a fair one, and people should be cognizant of that. And if there's not social work involved in an ongoing mature MLP, I think that you're not taking advantage of individuals who have an even greater opportunity to impact health, children, adults, and everything, beyond.
I was just going to say, your Wi-Fi was going out, and I hate that because I wish I was better at reading lips, because it sounded like you had some really great input. So I'll maybe touch base with you later, because I would love to fill in those gaps. But thank you both very much for what you brought to the conversation. Thanks.
Just a few glitches here and there. So we'll do our best to stitch that together, Jay, when we wrap up and transcript pulls it up. So apologies, everyone. All right. Anyone else want to share their MLP idea? What challenges maybe you're also facing, or what innovations you might be carrying out? Perhaps you're taking a new approach to integrating legal services into healthcare with a new healthcare partner type. See, we actually have Erica Kerber on with us today, and I really would like to begin to call on Erica if she's in a place where she can speak. Erica, apologies for putting you on the spot.
Yes,
Really,
hi. Can you hear
hi.
me? Can you see me?
Yes, we can see and hear you just fine. I know you're working on a CCBHC model, and perhaps not everyone's familiar with the CCBHC healthcare model that your legal team is integrating into.
So, and you know what, Bethany, I always forget CCBHC stands for.
Yeah, so Certified Community Behavioral Health Clinics, and
Right.
I will botch that the next time we do it. But
No, so
CCBHC.
exact. I always forget what the acronym, and I don't like acronyms just because of that. But we have developed medical legal partnerships with several provider agencies that have CCBHCs, and that's a new initiative. Some states are doing it. New Jersey, I think, was one of. I'm in New Jersey, by the way. New Jersey was one of the first states to implement CCBHCs in some of the with some of the providers, and it's really providing integrated care. It's like it's a clinical home where they're providing integrated care, both for behavioral health, substance use, physical health needs. It's no wrong door kind of model. Care is provided 24/7. So we have been working with these providers for even before they became CCBHCs. Once they implemented CCBHCs, it was kind of like a no-brainer. Again, because it really promotes holistic care. And so that's been working out very well. We're providing education to the clinicians and the other staff that they have. And we're constantly in consultation with them. We're consulting on cases. We're obviously assisting their patients as well. But, and Bethany, we met with leadership from the National Center for Mental Wellbeing about this as well. They were very interested in the work that we're doing. And again, this is through, CMS funds this model, and really getting CMS and other stakeholders to acknowledge the need to include this type of model, the medical legal partnership, legal services, and advocacy into the CCBHC framework. I think the providers see the need, but they always come back to me and say, well, we're not sure if CMS is going to approve it. We're up for a renewal. We're applying for a renewal. We're really concerned that CMS may shut it down or whatever it is. And I think if we can get leadership at the table, both on the federal side and obviously our state stakeholders. I mean, there's no question we should be doing work around our states, within our states and the legislatures. But CMS, SAMHSA, at the table and having a discussion with them, because the funds are funneled through them. Providers see the benefits of this. I think they're just nervous about whether they can use their funds to support this work.
Great, appreciate that, because you highlighted both the successes as well as the challenges that are playing out at the same time. And it's you know, the MLP story, it goes to sustainability, right? So you socialize the concept, folks have bought in, you're carrying out the work, and you're seeing the promise, and you're wondering how long will that light at the end of the tunnel stay on. Is anyone familiar with the CCBHC model? Because FQHCs as well as community mental health clinics are able to get this specific designation, so as to help them better integrate and pay for and increase access to behavioral health care services. And the way the CCBHC model is designed, it allows for, as Erica mentioned, more holistic care and case management, which really works well with the medical legal partnership approach to integrating legal services for more holistic care. Anyone have questions for Erica? If not, feedback on some of what she shared? And perhaps it's not using the CCBHC model. Maybe you are working on behavioral health care access and services through your MLP, and you just have some general feedback for Erica. Really appreciate Erica sharing.
This is April Merrill in Oklahoma, and we have a couple of medical legal partnerships out of behavioral health sites, and I don't know that either of the groups that we work with that have multiple sites across the state are actually certified community behavioral health clinics, but I am very interested in looking into that and having that conversation with leadership, because we definitely see the needs in those clinics. One of the places has 17 sites across the state, and the other has, I think, 13 as of this week. And so talking to them about that certification, I think, would be really interesting.
Great, April. We'll make sure we share some information about the model from the National Council for Mental Wellbeing in the chat, or following the town hall event today, and ensure that all the registrants receive that information. We know that folks are increasingly interested in the model across both sectors, and state Medicaid agencies as well. Look to it as a way to increase access to behavioral health services.
Bethany, this is Erica again. Can you hear me?
Yes. Mm-hmm.
I know this is kind of, I'm segueing into something else, but again, it's great that we're all talking to each other and sharing information. And I've spoken to, obviously colleagues in other states as well. But any thought or idea about convening another in-person conference so we can all get together?
Yeah, no, I think that's great, right? Because this is a virtual town hall, and I appreciate that you asked that at all. So when we begin to have conversations like this, part of our objectives as training and technical assistance partners, I see the chat, is to glean from folks who attend these events what your needs are and what sorts of emerging topics or areas you're beginning to address through your MLP practices, as well as innovations, and then those challenges. And so Erica is more than asking, is hinting that it's time for us to have this sort of peer-to-peer conversation, this sort of town hall at an MLP summit, and the National Center is definitely working on it. Some of the folks that you see attending today's event also are aware of our hope that we can bring the MLP summit back, or work with our partners to integrate medical legal partnership at their conferences. Christina is in the chat calling it right out. It's the MLP Summit, that's National Center's annual conference that we're trying to bring back. So cross fingers, we can have this sort of peer-to-peer exchange in a more natural but also exciting in-person sort of setting. And then also effectively capture the learnings from that sort of setting as well. So, Erica, if I can, I just want to tie that to what we're presenting on here today. Tell us why you posed that question in terms of, the ability to exchange or gather feedback from MLP peers, perhaps. I don't want to be too presumptuous, but tell us why you asked.
Sure. I think the last MLP conference was in 2018. Is that right?
2019, long enough ago, though. Almost that.
So I did not hear about medical legal partnership or really have an understanding until I went to the summit. It was fantastic. It opened up my eyes, especially when talking to healthcare providers. I mean, attorneys, we all know what we're doing. We're, the kinds of services that we're providing. But hearing the other side of it, and that definitely motivated me and impassioned me to really move this forward in my state. And I think all these, the Zoom meetings and the webinars and all this information sharing is wonderful virtually, but I think getting together in person and networking and making connections, and that's how I developed relationships with counterparts in California, North Carolina, Nebraska. I met all of those people at that summit, and we still talk to each other. Thanks. So it was fantastic. And, if we can convene another summit and to share what we're all doing and all the, the innovative work, and then I can bring it back and say, oh my goodness, look at Oklahoma, look at what they're doing. We need to do this too. Again, that was really the, I just actually presented on MLP right now before this. That's why I'm a little frazzled, but I just presented in my state to, providers about MLP. And, they mentioned, they talked about the term seed, is planting that seed. That planted the seed for me. And it's been never ending, and it's been phenomenal. So if we can just, again, and I had a great time in DC. It was fun.
Me too. I was there. I appreciate you helping me document this request, everyone, live and in the chat.
See, it's not only me. I'm just the troublemaker,
Yeah, no, I'm going to tie it to our well, it's tied direct. It's a town hall. Everything is tied to the conversation. Thank you, Erica.
No problem.
I'll go on the record officially. I want a summit.
Thank you. Thank you. That's exactly what I need. Keegan, I saw that you unmuted as well.
Well, I just wanted, I'm a fan of the summits. I remember my first one in 2010, maybe. I might be dating myself. But I do want to acknowledge how much work that is for the National Center, and just say that it is amazing that you all pull this off. But also, kind of recognize how much work that takes. And I want to talk a little bit, if I can, about some of the strategy on that in terms of thinking about provider organizations and trying to make MLP not just this siloed experience where those of us that know get together and we feel really great and we get new ideas and it's always so invigorating. And then we go back to nurses and social workers and healthcare administrators and doctors, and they're not getting that same experience always. And so one of the things that those of us that like to spend a lot of time talking about MLP are really trying to be deliberate about, I think, is taking opportunities to embed MLP in other conferences as well, right? To make it part and parcel of all the conversations. So I don't want to take away at all from the call from MLPs. I just want for an MLP summit. I want to say that I think hopefully you're going to start seeing MLP more and more in other conferences and other spaces. And then the other thing that I think is growing are the regional MLP conferences. So I know, for instance, in last April, and we will pick a date here soon. I suspect it will also fall in April of 2025. We'll be hosting an MLP conference in Texas. So be on the lookout for those regional opportunities. We didn't create that model at all. We're building on the foundations that other folks have laid, but yeah, so that's all. Yes, please, MLP Summit, but also everyone take the opportunity to just go into spaces you weren't even invited into.
I appreciate that, Keegan. I'm actually hoping to bring back the summit in addition to inserting MLP
Yes.
everywhere.
Yes,
So
and
this, I think this really highlights a really key challenge. I'm going to ask Reha to actually help me advance to the next slide. It really goes to, you know, our ability to share information and learnings efficiently and effectively to ensure that legal services are integrated into healthcare settings as a part of the healthcare delivery model. Perfect segue for me to ask everyone to take a moment in the chat, even if you've already mentioned it and it amounts to MLP Summit, one word or really short phrase to describe the most challenging aspects of MLP practice. Anything. I know folks also answered the other poll question already, which was about identifying the top 3 priorities that for MLP practice innovation that you're going to work on, but one word or very short phrase to describe the most challenging aspects of MLP. Going to begin to read out what's coming through the chat. Sigolene out in California mentioned data exchange, data and information exchange. Callie and Margaret mentioned funding. Ira, I think by support, it could be funding, it could be more inclusive in terms of how we're defining support. Erica's also mentioning funding and showing the data about the benefits. Keegan is mentioning space. Christina's mentioning funding and showing the benefits. Gretel Johns mentioned administrative bureaucracy. Gretel, I'm going to ask you if you're in a place where you can talk to share a little bit more detail in a moment about that. Oh, in April, Meryl mentioned funding as well as program evaluation. Huge hefty lift that program evaluation entails in terms of funding needs just to begin a properly designed and beneficial program evaluation. Just want to acknowledge that. All right, let me see if Gretel is able to share. Ira also spelled out in greater detail support, meaning funding, and in terms of support, such as buy-in from the program's leadership. That is indeed key. Gretel Johns, are you in a place where you might be able to unmute and tell us more about the administrative bureaucracy challenge that you identified?
Potentially. I feel like it's just that there is a lot of steps and things so that even when you're running your MLP kind of at the local level, I'm in a regional office, not at the like at our main office. And I often will have funders or providers who are on board, but getting the administration portion to actually do something with the money that we were given or approve something. It's just there's a lot of steps that are causing things to just not move forward. So that's just one of our problems.
Mm-hmm. Gretel, I don't want to continue to put you on the spot, but do you have like a specific example that you are able to mention so that we can provide some feedback or hear from the group feedback from the group?
Probably I'm going to decline to answer that without permission. Thanks, though.
I get it. We get it. We all get it. Safe town hall space. So let me know a couple of things because we have several MLPers on here who've probably been through this journey of administrative bureaucracy. And I know Keegan and Jay and I, all of us, we talked a lot about, for example, when you are working with a healthcare partner that may have general counsel, and general counsel is, you know, the initial stages of planning and implementation, hearing you propose to bring lawyers into the healthcare space. And perhaps you've been at a long-standing medical legal partnership and you are also suddenly facing these questions, perhaps from general counsel and a new fresh round of having to justify what work you're trying to get done. Keegan and Jay, any strategies for dealing with that? Perhaps part of or aspect of administrative bureaucracy, or even the information and data sharing challenges that people have discussed for integrating legal services. A lot of examples came up about evaluation, dedicated space that's confidential, as Jay mentioned in the chat, sustainable funding sources, right? That's certainly related to administrative bureaucracy, even outside of the partners.
Let me just tackle the really narrow issue that you just talked about, Bethany. I hope the connection's a little better. I think I figured out what was going on.
Perfect.
In short order, but you know, I think one of the most important things that folks can do if they really are running into some kind of administrative ceiling barrier is to reach out to some folks who've been doing this a while or who have other allies in those very administrative spaces who can help the kind of barrier folks understand that this isn't a thing, right? That this is not something to lose sleep over, that there are other, you know, this has been going on long enough so that there's barely anything that you're reinventing these days, right? There's so many different pathways and models that have already been, you know, taken. And so it's very rare that you would come across, I guess it's possible. So, you know, every institution and every healthcare center, or, you know, whether it's a qualified health center or a big, you know, academic medical center, everyone is unique, but there's very little that hasn't already been established in terms of individuals who can help lay that groundwork. So I would urge folks to utilize, at least I'm more than happy to provide some guidance to other folks, because a call from a administrator in one system can be extraordinarily helpful and really alleviate some of the stress. That doesn't take away the 89 other things that you have to overcome, like the dedicated confidential space, like the sustainable funding, like the how do we integrate data. But if you look at the, you know, if your overall overarching issue is that you're really getting some pushback and some there's real impediments at the high administrative level, and it just, nothing seems to be, you know, gaining traction. I think that, you know, we can certainly talk, or, you know, other lawyers can talk to those folks from the MLP side, but the administrative side, it can be really helpful if someone gets a call from a colleague in a different system that can really overcome some of the, and they can ask all the questions to the people who may have already had those preconceived notions or those, you know, those concerns. And I would urge you to kind of reach out to us so we can put you in touch with, or certainly be happy to try to lay some of that groundwork, because it can be really helpful to have somebody, you know, fears, which are legitimate, but I think can be overcome pretty easily.
Yeah, I think that's exactly right. There's quite a few of us that have done a lot of design consultation and evolution consultation, and even evaluation of programs that, and I'm going to speak broadly for that cohort and say we are all happy to come be a third party voice to help get things done. The other thing that I would say is, when I've run into barriers, it is almost always ground in professional values or ethics or regulations that are just different than mine. So I may have an idea about how I want to talk about something or what my approach might be as a lawyer, but if I'm not aligning that with the realities of, say, the FQ's reporting requirements, it's not going to get done. So what I need to do is make sure that I understand what is the actual barrier, because it's very seldom just that no one wants to do it. I have had that happen, and I won't tell you which profession was most responsible for that. But very often it's just that it's a different language, it's a different approach. There's something that's kind of in that profession. And honestly, we as lawyers have the ability to be really flexible when we allow ourselves to be. And so it can be small things. My law firm wasn't in the habit of reporting to funders on a monthly basis, but we had an FQ that said every other department that we fund provides us with the number of encounters every month, and that goes to our board. And how do we want to continue? How do you want us, the healthcare entity, to say we're going to continue to fund you, but you're not taking the time to provide this little bit of data? So we automated a report and pushed it out monthly so that they could talk to their board. So, and that increased buy-in. So sometimes it's just really about understanding that this is another industry with a whole other set of regulations and requirements. And if you can speak their language, if you can help them meet their needs, they will come to the table to be more willing to help you meet yours.
Really appreciate that. A lot of people, Jay and Keegan, also in the chat talked about showing the benefits. So ROI, whether social ROI, economic ROI, the outcomes, and evaluation, because I think we all acknowledge the challenges related to information sharing, data collection and information sharing. But once you get past that, right, there's this additional hurdle of designing an implementation or outcomes evaluation, getting funding for it, and then translating it into that impactful story for different audiences. Some of which, like Kate Marple had talked about, or what we had Aaron Davison, who presented with the Philadelphia Legal Assistance Team, conducted as a researcher. So for those who have found very challenging showing the benefits of MLP or conducting an outcomes or implementation eval, tips on where to start would be super helpful. And we'll do our best in the chat to also share some information about what we're working on with Kaiser Permanente, as well as our sustainability issue brief and some other resources for folks.
Well, I'm going to be a little bit of a troublemaker here because if we're going to talk about MLP summits, I actually think, and Bethany knows this, I think we actually need some time that's very focused on metrics and evaluation, data collection by MLPs, and figuring out what is it that everyone's doing. We have amazing issue briefs like the one that James Tufel just produced on metrics. But what are folks doing in the absence of kind of a national approach to data? In my mind, legal services collects an amazing amount of data. It's almost all unstructured fields, but I have found routinely that healthcare has no idea that that's going on. They have no idea that for every field in the EHR, there's probably a matching field in the electronic legal record, if you will. And so I think there's an opportunity to think about how you pair that information together. How to do so responsibly, of course, but I think both healthcare and law are fundamentally about treating patients and clients with respect. I think it's critical to remember that none of it is our information, insofar as we can't do evaluation because it's I have to protect the client. Well, that's the client's decision, actually, whether their data is going to be used, and if it's aggregated, it's probably okay anyway. Same thing on the healthcare side. So where do you start? I think you start with, what do you already have? I'm going to go back to a Texas example. Everyone who receives our state level kind of LSC funding, basic civil legal services funding, has a reporting requirement that includes outcomes. For every case, you have to select one of like 400 outcomes. When I read those, I realized that if I were looking at this through a health policy lens, these look like social determinants of health. So what happens if I aggregate those and use that as part of how I tell my story about what the MLP achieved? So that was something that we found really, really effective. So I think for me, it was always about, what do I already have? What do I already know? If I'm already collecting financial outcomes, can I tally that together and say, this is the amount of money that we put back in the hands of patients to be able to better afford healthcare services or their prescription drugs or whatever. So I think a lot of this, we have to do a better job of recognizing how much we're already collecting and leveraging that, maybe before we try to create new systems.
Yeah, I don't have a lot more to add. That's really thoughtful, Keegan. The proof is sometimes not in the greater, but in the lesser, also, to coin a phrase. But piggyback on what you just said, Keegan, you're already collecting an incredible amount of data, but your metrics shouldn't, don't shoot for the moon, just shoot for that first 10-foot level. Because if you show interim metrics that you're meeting, you are producing outcomes that are really tangible, and that combined with the anecdotal evidence of what you're doing is extraordinarily powerful. That's in the one category. Number two, look at some of the smaller outcomes that you can easily, or at least in an easier fashion. If you shoot for the moon and you look for improvement of health outcomes, we all know that, the holy grail that's been, tried for the last, 30 years. And that is an extraordinarily high bar, given what we're already dealing with in terms of the, legal determinants and social determinants that are so combined with the patient population that MLPs serve. But what if you look at one particular area? Let me give you a really brief example of former colleagues of mine that just looked at stress reduction in a mother-child kind of dyad. And what was the stress reduction for the encounter regarding electricity, turnoffs, and the ability to prevent electricity shutoffs in a particular pediatric setting? And the stress reduction resulted in X percentage, 72% of the families had a reduction in stress, which then produced a significant, reduction in the stressors that create all the other potential issues that that could affect the family. Look at some of those smaller metrics, look at some of those smaller outcomes if you're really interested in measuring something that's different than, as Keegan said, the data that you already collect. But how many cases are you dealing with? That's the most powerful number that administrators and funders will look at. Wow, you hit X number of families, or X number of population with COPD or whatever it is in terms of your defined population, and you were able to provide that encounter which reduced X number of encounters in shutoffs or court appearances or whatever it might be. And you have the opportunity and the ability to do that. So look within what you already have, rather than, again, Bethany wrote, look for public health folks. Absolutely, because they know what the data provides, aggregated, disaggregated, whatever you're looking for. But look at what you already have, and you can create outcomes within the pool of data that you already have, within the cases that you're already doing, within the encounters that the clinicians are already providing you with. And those conversations can translate into anecdotal and real subjective data that can be really powerful.
Mm-hmm. Mm-hmm. I was just thinking about some data sets that I was allowed an opportunity to do that sort of peek behind the scenes, and at least some anecdotal statements can be made about what they're producing. Appreciate that, Jay and Keegan. This actually segues into the next and final conversation. So we're going to launch a poll. Reha, let's go to the next slide. This is our third and final segment of the conversation. So let's launch the poll and talk about what's really missing from your toolbox as an MLP practitioner to drive improvements in health equity and outcomes. Are you missing research capacity? And you can also include program evaluation in that bucket. Are you missing for your ability to drive improvements, increased awareness of medical legal partnership? As several folks noted in the chat, maybe funding is the missing piece here. How about policy changes? And would love to hear from folks who are beginning to indicate policy changes are missing from the toolbox, or maybe there's something else. Give folks a couple of seconds. We have about half of our responses in. We're going to close out in about 5 seconds here. So let us know what's missing out of the categories that are showing up on the screen. There's something else or other bucket. What's missing from your toolbox to drive improvements in health equity and outcomes? All right, so you can see from the results on the screen, most of you actually indicated that you're missing from your toolbox research capacity. And remember, just broadly speaking, that could include program evaluation. Several folks also indicated that still we need increased awareness, just that, of medical legal partnership. And I absolutely agree. Funding as well, agree. Policy changes. I'd like to ask the folks who check that box off to raise your hand so we can unmute you, or you can unmute yourselves actually today so we can hear more about policy changes, at least identify them for us today. And then someone actually bravely and courageously check the something else box. So let's stop staring on the screen, move to the next slide to get the facilitation questions to come up, where we explore some of those tools, methods, and real world applications of the MLP that drive improvements in health equity and strategy. Who joining us today checked off the boxes related to not other, but something else is missing from the toolbox, or that policy change is missing? Let us know who you are. We'd love to hear what specifically you're identifying as potential policy change or policy, as well as the something else category. Anyone brave to tell us, come out from behind the aggregated data that was in the poll to let us know more? Because we had the conversation, we had a pretty rich conversation about research capacity and program evaluation. So we'd love to hear more about some of those other missing tools. Margaret is mentioning, Margaret, you wanna, oh, sorry, go ahead.
Sorry, Bethany, this is April Merrill with
Thanks.
Legal Aid. And I was just going to say what I was meaning for the policy is we had a very specific situation come up several times around the reporting requirements for APS with some of our elderly clients. And in Oklahoma, the reporting, they have like a list of people who are mandatory reporters for APS, but for adult protective services, for child protective services, it's everyone is a mandatory reporter. And so we actually took those to our legislators and asked them to consider allowing us to make referrals without violating our attorney-client privilege responsibilities, and to either specifically list us or make it analogous to the CPS referrals, because we were seeing all of these hospital-based adult guardianship cases coming through over and over and over and over again, where we would get involved and then we would start realizing like, oh man, this is not a good situation, but we couldn't make the referral.
Real world application of MLP going upstream and fixing that problem that you and your clients were facing.
Yeah.
Thanks, April. Appreciate that. Right on point. So April was one of the folks who chimed in the poll to identify policy changes or strategies that were missing from a toolbox that an MLP can address. Anyone else want to share? I know someone had indicated that something else is missing. So I will say one of the things that I think is missing is really the freedom to define an MLP as you wish. We talk about it as a very flexible approach, and we increasingly see people experimenting with the flexibility of that approach. So many of you that are joining today are in civil legal services, but some of your colleagues out there are actually beginning to broaden the definition of that L in MLP to work with public defender offices, or even go even further into systems that might be operated within the criminal justice involved population space, and working with jails or prison systems. So I actually want to call on Keegan for this particular question, because Texas A&M University, if folks were watching, and then I also want to call on Georgia Legal Services Program in a moment, but start with Keegan to highlight this new partnership that Texas A&M University has with Federal Bureau of Prisons and Department of Justice. The Office for Access to Justice is working with y'all on it, Keegan, and that really begins to, I think, help us think about how to apply MLP and bring more tools and partners into our strategies and approaches.
Yeah, I think that's exactly right. So the long and short of, we have several MLPs that we're launching. We haven't gotten to share all of that yet. Just broadly, but one of them is in a federal prison camp. It's a women's federal prison camp, and we are putting civil legal attorneys and law students and medical students all in the same setting and asking them to work to achieve really three aims that we're interested in, right? So we are an academic setting, so we do get to do kind of all the parts of MLP, the direct legal services, yes, and we have a really very focused set of legal needs because we'll be working around SSI in particular, with everything else becoming an ancillary program. That's really important in Texas because we haven't expanded Medicaid, so SSI gets you Medicaid. So what are the three things that we're looking at? Well, we're looking at recidivism, because there's some evidence base that suggests that Medicaid receipt reduces drug offenses. It reduces really things that are fundamentally financial crimes, and et cetera. We're looking at access to housing. And we are looking at access to care, again, because of the Medicaid component. So it kind of, because of the way this is set up, is breaking some pieces of the MLP model, and other parts we are getting to be really deliberate about, like, let's teach medical students how they're an example of how medical records are used with or without their permission, and has an impact on their patients' lives, right? Those of us that have done SSI cases know that medical records are kind of 100% of your evidence base. So let's have that conversation. Let's train this next generation to do a little bit better. So training, direct services, research, we do kind of get to do a lot with this project. I'm really, really excited about creating a model that hopefully can be rolled out. And if anyone has any ideas, I'm open to those.
So I know a couple of people just hopped on while you were explaining that new application of MLP, where you're partnering Keegan, Texas A&M, with Federal Bureau of Prisons, and it's a women's prison. Just to reiterate some key points there. And so there's a pilot also with Department of Justice involved. We're really broadening the application of MLP, ensuring that people understand it's a flexible approach. And there are others who are partnering with public defender offices. So we're aligning this work that we do increasingly with all of the bar, right? The legal services providers, including our law students, and really going downstream, if you will, or further earlier into the pipeline, where we have med students and law students, to ensure that through the educational system and settings, we can also embed MLP as a strategy and approach. Any reactions to what Keegan and her colleagues are working on in Texas? Anyone? Like, what? Is this still MLP that we're talking about?
This is April in Oklahoma, and Keegan, this is so incredibly exciting for me, considering that we have like the highest population of incarcerated females, I think, in the nation. Maybe we're number 2. We go back and forth with Louisiana. I'm not sure the numbers right now, but this is amazing. And we actually have a partnership with a group called Women in Recovery right now. Okay. It has not been classified for us as a medical legal partnership, but is very much aligned with exactly the model that you're proposing. And it makes me a little bit curious if maybe we shouldn't realign it. We have considered it a embedded attorney at a mental health facility, but they don't consider it under medical legal partnership. It's really focused on reintegration of incarcerated individuals. And so that really excites me to think about that as a medical legal partnership, because I do think that it essentially is the same model, just I hadn't categorized it in that way in my mind. So thank you for bringing that to my attention. That is so amazing that you're working with the prison system.
Yeah, I'm really excited about this. I would love to learn more about the work that y'all are doing and particularly the mistakes you've made so we can avoid those. I'm sure there's not many, but there's always those little bits of learning, you know.
Oh no,
So
we've made plenty of mistakes, and I am happy to share all of our mistakes with you
Yeah.
because that's how we, I mean, we've been doing that project since 2011. That
Okay.
particular project. And so
Yeah.
we've made a lot of mistakes, and I am happy to have that conversation with you offline too.
Yeah, absolutely. Can I ask you where you are? You told me Oklahoma. Where in Oklahoma?
I'm in Tulsa.
Okay.
And the program that we
MLPs.
work with is called Women in Recovery. So you can look it
Okay.
up, or I can send you a message with it. So.
And in April, you all have at LAOK, which I think also the other lasso.
Yeah.
But y'all have MLPs throughout the state. Really, you have a lot of MLPs.
Yeah, we just
to,
opened our 22nd one.
mhm.
Nice.
Yep.
Nice.
So speaking of MLPs in the South, I want to call on our friends from Georgia, where I'm actually physically sitting. And Reha's already teed up just some quick highlights to show off that they are the subject of the latest medical legal partnership spotlight, where we really highlight the role that MLP can play in very, very rural areas. So Ira and Rachel, just in case folks missed the presentation that you all were on a couple of weeks ago, I wanted to, if it's okay with you, call on you and Rachel to really talk about, how you overcame this challenge of starting a medical legal partnership in a rural area. April and Keegan are also working in states with very, very rural populations. And it's not easy, right, to bring lawyers there. And also we know that healthcare is also, the infrastructure is very poor in many of these rural areas. So Ira and Rachel, can I put you on the spot to talk about how you were able to bring MLP to a very rural area?
Sure. And thanks for the highlight and thanks for the plug, Bethany, and everyone. I want to give credit to Rachel Henderson for the medical legal partnership that we were able to start in Waycross, Georgia, which is in one of the most ruralist parts of Georgia. Waycross, Georgia is located in South Georgia on the Georgia-Florida border near the Okefenokee Swamp. And there are not that many lawyers in Waycross, which is Ware County, and the surrounding areas in that South Georgia region. But again, I want to give credit to Rachel Henderson. Rachel is a specialist attorney with Georgia Legal Services Program, and it was because of a special relationship that Rachel has with the director for McKinney Medical Center, which is a federal qualified community health center. But I want to give credit to Rachel. So I'll stop at this point and let Rachel say something, because again, without her, we would not have been able to establish that community health medical center about 2 years ago.
Rachel?
Yes, thank you for the opportunity, Bill. First of all, I want to give credit to the CEO of the McKinney Medical Center. She is really one of the most innovative partners you could ever have. And I appreciate what Keegan and Jay were saying a few minutes ago, because she's constantly pushing us to do additional things. She said, okay, we work with you social workers, we know something about Medicaid. And the other day she indicated, I want to push harder for Medicaid for women, because we have a ton of rural women coming in totally without access to care, pre-delivery, and even the nurses see it, the hospital gynecologists see that. That's a really devastating health issue. People don't have any income. So she wants to push for expanded projects. She also has a project that most of us don't talk about on a general way, is they provide rural health care to migrant farm workers. Their employees literally go out to the farm camps and provide screening and access to medication. But the thing that I'm beginning to realize now is she realizes that, and the data we have provided she acknowledges and indicates what Keegan was saying just a minute ago. And I think I want to expand on that. I think that would be the next step, how we do the outcomes components, because she's right. Legal services requires that we provide so much data in terms
Right.
of the clients that we see. Each and every other encounter has to be noted in the file. You have to notice, did you give advice to anyone? How many people literally came to see you? How many phone calls you have to receive on a monthly basis? And all of that data we've been keeping and providing. People we provided just advice to, care and assistance to, utility issues that you just made reference to, termination of utilities. That's illegal if the person has a medical prescription. So working with those doctors, providing that, and SSI and Medicaid, all of that. We need that data, but and we are going to do that, wants to expand even further. So we're getting more dispossessories coming in, more kids with educational issues. So those are the kinds of things that you can push and talk to people about in rural counties. And as Ira said, because we are rural, if you are successful with one senior, for example, you are successful with every senior in the community. So the numbers are driven. I'm like, Hagan, how do we do the outcomes for future funding strategies? And the other issue in terms of legal services, and she's aware of this, is the capacity to handle all of those new and additional and varied and variety of people who are coming in, including homeless individuals who have been released from incarceration. So we're working on getting SSI applications in for them, access to medical records from prisons. That it's a challenge, and she is leading that challenge. And I am stimulated though by this whole discussion, because I can work and do additional sharing with the social worker, which she now has on board. So all of that makes this for an exciting endeavor, especially in our small rural community.
Rural, extremely rural. I can't stress that enough. And I often say, if it can happen in Oklahoma, if it can happen in Texas, if it can happen in rural Georgia, trust me, this is nothing like what you all see on TV about Atlanta or what you'll see tonight during debates on television. It is rural Georgia, and they managed to get this done, right? Recognizing each other's capacity and looking at data now and being able to begin to not necessarily predict, but plan for the future. So they're thinking about the present as well as the future, and what they can actually at least try to achieve together. And Jay also put in the chat, Jay, I don't know if it's okay for us to call that out, that's exactly what you're talking about in practice that Rachel's doing, that you have so much data, so many numbers, and you can create outcomes when you're thinking about the efficacy of what your partners are requesting, including the healthcare partners who can also go in and ask in different funding spaces for resources to support your legal services work. And they don't necessarily have to keep tapping into the same original source of funding. Remember, they are also in places and spaces where legal services may not be able to go to advocate for funding, but also that our funders perhaps are specifically looking at healthcare and healthcare delivery models and want to know about the innovative work that those healthcare partners are doing. Ira, you're unmuted. Want to help us close out?
Yes, I just want to reiterate the partnership with McKinney, the rural MLP that we established. Funding, the relationship allows for that we've established with McKinney allows for the McKinney Medical Center to apply for 330 funding on a yearly basis. And so now Georgia Legal Services Program, we are written in their yearly application for funding that they receive, their federal funding application. And so that funding allows for us to provide for staff and the services that we administer at the MLP site. So it's a win-win situation. We help McKinney by seeing some of their patients that have legal issues, and then we are helped, Georgia Legal Services, we are helped because, again, we have the capacity now to bring on an additional staff member that's covered by the 330 funding that the McKinney Medical Center receives. So it's a win-win situation. And then also, my closing comment is that when I did the data regarding the report that we would give to the director for McKinney on why the MLP was so needed, the data showed that almost 20% of these individuals that live in Waycross, Ware County, where the medical legal partnership is now located in the health center, about 20% of the individuals were low income and underinsured. And so again, that shows that connection on why medical legal partnerships work so well with community health centers. You have that legal component and that medical component that work so well to provide services for folks that are needed. That 20% of folks down there that are low income, a lot of those folks, in addition to medical problems they have legal issues also.
Agreed. Ira and Rachel, I want to thank you all for sharing, as well as everyone for chiming in and really having a robust conversation. I'm going to attempt with our partners, Keegan and Jay, to craft some takeaways as it pertains to this conversation, and let people know a little bit about what to look forward to, in addition to, for example, the MLP Spotlight is a key resource. I think, Reha, if you want to, you can skip past this and you can land on any slide that you want. We can stay there in terms of key resources if we want, since we're wrapping up the series today. So on today's conversation, we really walked through three key areas of conversation, right? So we started off with presenting what we're working on as MLP practitioners. We heard a little bit about new applications of the medical legal partnership model to behavioral health, as well as expanding and enhancing our use or integration of social workers. Then we started to talk about, some key strategies or challenges related to integrating legal services into healthcare settings. Folks continue to lift up the need for training in settings such as in person, so we can share this sort of content and information with each other about the success of the MLP approach and then how to overcome challenges. And folks also highlighted that pressing need to identify funding, but as we all know, you have to produce data related to the need for funding as well as the outcomes for using that funding. So data absolutely matters. And that's actually where we landed on when we talked about that third area of objectives for today's conversation. And that was tools or methodologies, real world applications of MLP, where folks identified everything from policy changes that an MLP can identify and address, as well as leveraging data that you're producing right now in real time to get continued buy-in from especially healthcare leadership, as well as the legal champions, right? You heard from the Georgia program that Ira Foster passed the mic right away to Rachel Henderson, who's that legal champion. So don't discount the role of your leadership in MLP and in the L category. You do need a dedicated legal champion who will be available for the development work, not just the actual implementation of the approach, but the actual development approach, and can have that continued conversation and relationship with the healthcare champion who can help you push the envelope, if you will, to be able to carry out those new approaches, such as what we heard from Keegan in Texas, working with Federal Bureau of Prisons, that hopefully we'll see be replicated in places like Oklahoma, for example. I tried to share some key takeaways summarizing the conversation according to our three objectives for today. Let me turn it immediately over to Keegan and Jay to see if they'd like to help me further refine that or add to that if I missed anything major. And then I'll ask Hannah, our staffer, to also share in the chat directly with everyone some of the key takeaways from the notes that Hannah was taking. Thanks, Hannah. Thanks, Keegan. Thanks, Jay. Jay, you're first.
I'm first. Okay. So I'm going to do two quickly. One, I'm going to be a troublemaker, like Keegan said before. I'll save that. The first, though, is to reiterate the points I think that everyone has said, but I really want to focus on, which is that there is so much opportunity within the boundaries of what folks already do to harness not only the data, but look at discrete kind of low-level, mid-level, and higher-level outcomes that you can translate into, metrics that will be successful in looking at, we're handling X percentage of population that have this particular medical/legal need, and we've been able to satisfy, X percentage of those people that wouldn't have ordinarily or had previously been provided with that kind of legal health assistance. And that's the kind of thing that I want to reiterate again, that the data and the opportunities are already there, but think creatively about how you can use those in a way that can really benefit your program. The second, this is where I'm going to be a little bit of a troublemaker, is that I don't think we do a good job. And this is not an indictment about anybody. This is an indictment of the 30 years of medical legal partnership, so to speak, or 25, however you want to call it. But, if you're on the healthcare side and somebody walks in, and there's protocol for almost everything that takes place in a healthcare setting, right? If you come in with a certain presentation, there's a protocol for residents, for emergency department folks, for health center folks. And that protocol is developed, it's refined, and it's improved constantly, right? That's quality improvement in the health setting. We don't do that very well in medical legal partnership. There's such a disparate but incredibly powerful range of different protocols around the country. And we, in terms of people who've been doing this, have not done a great job. And again, that's not anyone's fault, and that's not to cast aspersions on anyone. It's just the nature of the being. The medical system is what it is. It's developed over, X number of years and different systems, but this is still an infant if you look at it compared to the size and scope of the healthcare systems and the legal services systems. But in this integrated model, there could be so much of a better glide path or pathway into protocols that are available for everyone to create that opportunity to look at the 20% like I was talking about in rural Georgia. In fact, I would have bet a lot higher than that, than 20%, frankly, but that's really interesting data for another day and discussion. But how are we dealing with this percentage in terms of the inequities or the equities that we're trying to deal with and attack? So I think that the one takeaway I would have is there's still so much work to do, but there's so many thoughtful, incredibly powerful resources of people who are doing the work. And that's kind of the next thing that I think on the agenda for medical legal partnership. I think that we could have that kind of, available resource center. And I say that metaphorically, whether that's, something you can grab in a protocol online, or whether you have a list of folks who've already developed this, whether it's the white paper that, Keegan put out, et cetera. But again, wow, I never saw that. I should have, and I probably did at some point in time. But these are things that should be second nature to medical legal partnership, just as they are if someone comes into a healthcare setting with a certain complaint, you know exactly what's going to happen. Anyway, that's my second takeaway.
Wow. Y'all have summarized all the things, so now I have to try to find one. I think my big takeaway is that there's a lot of power in who we are collectively. I will say I'm actually really excited by the number of times that I heard MLP or medical legal partnership used in the singular, as though we are one united field and not a bunch of disparate folks trying to, do good, right? But that we have a common cause and a common opportunity. And so I think that's personally a bit of my takeaway, and I'm really excited about that because I have frankly fought some journal editors over the use of MLP in the singular, of medical legal partnership in the singular. But I think we're a field, I think we're a collective. And so so what does the next stage look like? I don't know, but I have a feeling that there's a whole lot of folks on this call that are going to be part of it. The other thing that I really want to invite, I spent a long time on the ground, and one of the things that always struck me is it's so hard to tell your own story while you're doing the work, right? How do you tell the story of the work? So please, please, please do not hesitate to call on those of us that I hope no one at A&M is listening, have a little, who have some time to just think about things. We have time to write about things. Let us help the work amplify your voice wherever we can, because that is something that would be personally really meaningful. But it's also something that I know that when I was on the ground as a practitioner, that I really struggled with. So always happy to be a resource to help you think through whatever, and best of luck to everyone. I'm excited.
Same. Keegan and Jay, thank you so much for really helping us not just wrap up today's conversation in a really helpful, comprehensive, and holistic way, but encouraging us to keep doing what we're doing and push the envelope so we can get more done to achieve health equity and justice for all, is what I like to say. We're actually not just doing access to justice, but achieving justice, right? So with that, we are finally at the end of our Health Center MLP Planning, Implementation, and Practice webinar series. I want to sincerely thank Jay Sicklick and Keegan Warren for partnering with us on this training and technical assistance webinar series development. The National Center for Medical Legal Partnership also wants to thank HRSA for funding us to make this possible for all healthcare and legal services providers that want to work together. What's next? The National Center, well, what's immediately next is please fill out that survey so that we can gather feedback about this webinar series and today's event. But look forward to another survey coming up. Folks dropped more than a hint that it's been a while since the National Center has been able to push out some very key, important materials. And one of those materials is the MLP survey. So we also value data, and one of the most important pieces of data that we collect and analyze here at the National Center is on the landscape of medical legal partnership growth and development. So look forward to that. Reha is our data scientist on the team. She's not just the person behind the scenes running our webinar, she's actually a data scientist. And so she's leading that, and we're hoping, I'll just put it out there now, to work very closely with the Legal Services Corporation and their chief data officer on that project and initiative. So please, folks, we hope everyone will be able to fill out that survey. Also, we have Maria Casonia on our team, who's leading the development of the MLP literature review. And you all got a chance to very quickly meet Hannah Silverman on the team, who'll be supporting both of these efforts and has just recently joined the National Center team. You'll probably see her on our Kaiser Permanente project a little bit more often. So look forward to the MLP survey and the MLP literature reviews. Tell us even about abstracts that you are submitting and perhaps aren't yet published yet or may not be published until 2025. We'd like to know and begin to put it on the list. And then right now, in addition to that survey, share your contact information in the chat or in a DM so that folks can keep in touch. We really want people to continue to, until we bring our MLP Summit back, continue to treat each other as resources. So that we can help this field continue to grow and MLP to become the norm in all of our healthcare and legal services delivery models. So with that, we're going to close out, and I wish everyone well. Stay cool and healthy over the summer, and we'll see you back here in or around August. Thanks, everyone. Have a great day.